It's wonderful to have Rekha Pai Mangalore joining us. For those of you that don't know, we are both in Australia, but we're at different ends of Australia. But you'd never know because New Zealand's called Aotearoa, which means the long white cloud. Australia is currently the long black cloud, and it's very wet here in Brisbane. And some 3,000 kilometres away in Hobart, where I think Rekha is, in the small island off the bottom of Australia, Tasmania, it is also very wet. But Rekha is an infectious diseases physician, has a very big interest in beta-lactam dose optimization, which was her PhD topic. She works at the Alfred Hospital and is participating and leading some very important research topics in and around this area. So it's very nice that we can welcome her to present on dose optimization for Staph aureus bacteremia.
Thanks, Jason. And yes, I am in Hobart. It is very wet and very cold. So yeah, it's not great. Hi, Erin. And I can attest to how much hard work that was for Erin. And you were awesome in leading that whole effort on ibex. So congratulations. I'm going to talk about dose optimization of beta-lactams, actually, cefazolin particularly, in Staph aureus bacteremia. And this is actually a project that I'm supervising, and my trainee is pharmacy advanced trainee Leon, who unfortunately couldn't be here to present due to some unforeseen circumstances. So I'm filling in for him. But I have to acknowledge that he did all the data collection, and it's preliminary data. So we still have another 50, 60 patients to go. So you are seeing this for the first time as well. So yeah, that's Leon. And then Sue, of course, a biostatistician who's helped with the data analysis, and then our drug lab and our patients. So I just want to acknowledge all these people up front. So I guess, we all know, and Erin, you've given a fantastic background for why we need to individualize beta-lactams and cefazolin under the broad umbrella of beta-lactams. So we know that from the SNAP study, landmark study, which is yet to be fully published, that we are moving away from flucloxacillin towards cefazolin as the first-line therapy for MSSA. And depending upon whom you talk to and where you are geographically, you will very strongly be recommended cefazolin as the treatment of choice. And yes, so we've seen that it was efficacy-wise comparable, and there was a toxicity signal with increased AKI rates in patients who were treated with flucloxacillin in the SNAP study, and also some mortality, a higher mortality in patients who were treated with flucloxacillin, and hence the recommendation to move to cefazolin. But we know that there is less or almost none pharmacokinetic or even TDM data on specific cefazolin TDM on MSSA bacteremia. So there's a gap there that we need to try and fill. And I know that a lot of us are trying to fill that gap at the moment. And just like what Erin said, there's a lot of reasons why beta-lactams are so variable in different patient populations. They're all subject to renal clearance, and they're all hydrophilic, so and have a small volume of distribution, and so they do physiology affects the sort of beta-lactam concentrations, at least in the blood. So bearing that background in mind, there's also this thing about cefazolin protein binding, right? We traditionally thought that cefazolin is highly protein bound, but it can be highly, but it can also be a protein bound towards the sort of moderate binding, which is about 70% or less, depending upon the patient's physiology. So that's another thing to bear in mind with cefazolin. The local context is that my PhD was also at looking at implementation of beta-lactam therapeutic drug monitoring, a little bit like Erin's. So we did a few studies to demonstrate that there was some benefit to therapeutic drug monitoring of beta-lactams, and managed to implement a full-fledged beta-lactam TDM program. We don't have a large amount of beta-lactams that we monitor at the moment, but we have the famous 5, as I like to call it, the 2 anti-staphylococcal sort of treatment beta-lactams, which is fluclox and cefazolin, and the 3 ICU beta-lactams, which is meropenem, piperacillin, and cefepime. So we introduced our program in December 2024, and we run trough levels every day, and we only have total levels, not free. We obviously, the MIC is a problem. We don't report our individual MICs in our lab, given that it is a derivative method and exactly what Erin said, it's variable. So we just get a S, I, or E, which is susceptible or susceptible increased exposure or resistant sort of reports. And we just have used the echo for as the MIC target. So that's 2 milligrams per liter. And we have opted to use a conservative sort of protein binding for cephazolin of 90%. And our target time over MIC is 1 to 4 times MIC. And we assume that by aiming for total concentrations of 20 to 80. So in our guideline at the Alfred, we have actually given people concentration thresholds as opposed to just saying 100% time over MIC. I can just show you. Yeah. So I have this is the sort of dosing algorithm that's it's a very simple one to follow. It's the dosing algorithm that we have in our guideline, and we've given people a sort of method to increase or decrease doses based on what concentration they see when they do a TDM, for patients. Our intention is to get the first trough concentration at 24 hours, and we try our best to achieve that. Of course, if it's the weekend or there's a public holiday, then that kind of falls by the side. We do use as high doses as possible. If the trough concentrations are low, we have used up to 2 grams Q4H or continuous infusions for cephazolin. Anyway, so the aims and objectives here, we just wanted to. The purpose here was really to to see what proportion of patients who are receiving cephazolin inverted comma standard dosing for MSSA bacteremia, and how many of those are actually achieving the targets that we've set out. And then we had a few secondary aims. We wanted to see what the impact of creatinine clearance was. No guesses there. And then the impact of the cephazolin trough concentrations on bacteremia and time to microbiological clearance, and also to see how we were performing from a sort of clinical utility perspective. Are we getting these levels in time, etc.? This is preliminary. We obviously want to analyze this further once we have the full data set. So we actually have 69 patients, because I was going through the data in the last couple of days, and one of the patients should not have been included because they did have a cephazolin therapeutic level, but they were not MSSA bacteremia. They had MSSA in a wound. So it's 69 patients, not 70. They should have had at least one blood culture positive for MSSA. They should have been on cephazolin, and the intention should have been that they are going to have cephazolin for more than 48 hours, which will happen with MSSA bacteremia. And that at least they would have had one cephazolin trough level measured. We extracted the data from EMR, and we do have a sort of database of all the levels that we do that is easily accessible. So we interrogated that database and connected it with the patient demographics and the infection characteristics. We looked at the renal function and albumin and the dosing. So all of those data were collected. We had 4 categories just to complicate it a little bit. It was subtherapeutic, less than 20. Therapeutic was 21 to 39 or 20 to 39 for ease of analysis. And then optimal, which is when you really want to ensure that you have that, hopefully that, 4 times over the MIC, and you hope that the concentration is good at the site of infection, because as you're aware, MSSA bacteremia can be quite complicated and can be deep-seated. So we had a range called as optimal, and then supratherapeutic, which is greater than 80. This is just a snapshot of the therapeutic guidelines that we follow. The most recent guidelines say that you may consider a 2-gram loading dose, and they've said normal for GFR greater than 40, which is 2 grams 8 hourly at the moment. And then if your GFR is 20 to 40, you go 50% of the 8 hourly or 100% 12 hourly. So if it'll be maybe 1 gram 8 hourly here and 2 gram BD here. And if it is less than 20, the GFR, then you go 25% or 50% of the dose. So you just have to calculate that based on what you think is happening at the bedside if you don't have TDM. Coming to results. So as I said, we had 69 patients. You can see that our median age was actually young, 55 years of age, with IQR of 45 to 75, mostly men, with only 20 being female. Our BMI was 26.8 median. We do get a large cohort of persons who inject drugs. So we had 19 in this cohort, but Alfred does look after a large cohort of patients who inject drugs. The onset of bacteremia, so community onset was the common sort of onset. Hospital or nosocomial onset was lower, 14.5%. And a good portion of these were complicated bacteremia. And by complicated bacteremia, I mean any deep-seated infection, like endocarditis or osteoarticular infections. Quite a few had required ICU for their admission, and our sort of median Charlton's comorbidity index was low, and our creatinine clearance was 85. And just these are the commonest sort of infection syndrome was bone and joint, and spinal infections coming second. So our median index dosing, everyone gets started on 2 grams 8 hourly, although recently, because these data are, we're looking at the whole of last year. So we're looking at 2025 at the moment. So I have seen a shift, and I'm just going to be anecdotal here, that in the last few months, people have been opting for going to higher doses of 2 grams 6 hourly straight away. But when we were looking at these data, our median dose was 2 grams Q8 for the first index dosing. And then, of course, based on renal functions at admission, the index dose, the starting dose was, can be lower depending on the guidelines that people were following when they started the dosing. The frequency most commonly was intermittent. The infusion was most commonly intermittent. And as I said, 8 hourly, 55%, 6 hourly, 24%, and then, of course, 12 hourly when there was renal impairment. In terms of who were subtherapeutic, therapeutic, optimal, and supratherapeutic, this is a common sort of finding that we see about 30% to 40% of patients on beta-lactams do not achieve that target that you aim for. And that's what we saw with our cohort as well. In the therapeutic range and the optimal range, if you want to just think of greater than 20, we had 9 and 24. So a good portion of patients were therapeutic, and then 9 were supratherapeutic. And we are in 2026. I thought I'll play around with Notebook LM. So I just popped these data in just to create some figures to see what they look like. Anyway, so we had a trough level, and then we looked at what people did to adjust the doses. How did they look at our guideline? What did they do after they saw that index trough level? And we saw that there were dose modifications. So about 34 patients required dose modification. So almost 50% of our cohort needed some form of dose modification. And 20 of those were actually increases in the frequency. So people went to 6 hourly if they were on 8 hourly. And then there were infusion adjustments, and all of these were either prolonged infusions or continuous infusions, and mostly continuous infusions. And just one person actually had the strength of the dose changed, which was 1 gram to 2 grams, but otherwise we just kept it at 2 grams. No one went to 3 grams Q4 or anything like that. And we're quite pleased to know that our troughs were correctly collected. So nearly 90% of the patients had their troughs collected exactly how we wanted them to be collected just before the next dose. So that was good. And I think this is a little bit skewed. As I mentioned, I didn't have enough time to actually look into these data myself. But this is better than what it was. Our median time to a TDM result is actually about 24 to 36 hours now. But these data, it was 110 hours with a IQR of 72 and 190. Again, there's weekends here, it skews the data. So as I said, I'll just put this in a table, but a good portion of patients had their TDM collected as we wanted them to. And I've just basically put it out here that how we adjusted the doses. And the last bit here is the important bit. 64% of the patients who had a dose adjustment actually then went into the therapeutic range. So that was good, but there was still a good, 12 patients who did not achieve therapeutic levels despite dose adjustments. This is hard to actually make any good conclusions of because it's a small cohort. So I'm just going to put it here. This is exploratory, preliminary, just, I wouldn't take too much away from this. Just that in-hospital mortality is low. It's, people come to the Alfred, it's a quaternary care center. They get really great care and their mortality is lower. And also our cohort of patients was younger. So just bear that in mind. So in-hospital mortality was 5%. And causes of death, deep-seated infections, MSSA bacteremia is bad. But we had a good clinical success, and we defined that as resolution of symptoms just with antimicrobial therapy or resolution of symptoms with antimicrobial therapy and surgical management. And the overall success rate was 69%. Failures, we included patients who had to go on to suppressive treatment and failures. And you can argue that that's probably not the right thing to do. So if we don't include that, our failure rate will be lower. But if you say that suppression is kind of a failure of management, then our failure was 27.5%. And failure included suppression, mortality, readmission, and change to an alternate antibiotic. We didn't have that many adverse drug reactions, and how we looked at these was whatever the clinicians had documented as cefazolin being the reason for an adverse drug reaction. So if I went and wrote a note saying I attributed a kidney injury to cefazolin and I changed the antibiotic to something else, then that's what we just took as the truth. Although we did have one case of AIN to cefazolin, and they had a biopsy, and it was a biopsy-proven AIN. So one of these was a biopsy-proven acute kidney injury, and the other one was just renal functions going off and the antibiotic being changed. We did not see any LFT derangements, significant LFT derangements. Patients with sepsis can have LFT derangements, but nothing that would fit into a drug-induced LFT derangement. So here comes the fun bits, if you like. I mean, we prove what we know. The creatinine clearance, the higher your creatinine clearance is, the lower your beta-lactam level is going to be. So, 39% of the patients, they had super high creatinine clearances, and they did have subtherapeutic levels. And those who did not have, those whose median creatinine clearance was 19.1, they were more likely to have supratherapeutic concentrations. And we use Cockcroft and Gault to calculate our creatinine clearances because that's what we have. This was an interesting, and I think this needs to be looked into further. I hope that we'll have some really good prospective studies that we can do, or really have a large cohort of patients that we can actually examine this sort of finding on, which is the clearance of bacteremia. What we saw in this cohort was that patients who had subtherapeutic index levels, their first row, were significantly associated with persistent bacteremia. And we define persistent bacteremia as bacteremia persisting for greater than 48 hours. And same thing with time to sterility, of course. From the index positive blood culture to the first negative blood culture was longer in patients who had their index cefazolin level that was subtherapeutic. So I'm going to talk about just cautionary things here first. Very small subgroup sizes. So even if when you break down from the cohort of 69 to therapeutics, supratherapeutic, they literally have very small numbers of patients when you actually try to analyze by breaking down the groups. When you break down the groups, you see that patients who were the groups are not balanced at all, and it was picking at straws really to actually show all those data on this presentation. But patients who had subtherapeutic levels were significantly younger. Their median age was 47 when you actually looked at that cohort, and they were healthier. They literally had no comorbidities. And the patients who had supratherapeutic or optimal sort of levels were older. and they did have comorbidities. So there is a difference here. There is, of course, selection bias. We did not include patients who did not have cefazolin levels. Who knows whether they did well? There would be some patients who would have been missed. So, and they probably didn't have cefazolin TDM because the clinical teams did not think that they needed it because the patients were doing well. So we would have missed those. And then, of course, the subtherapeutic group, they did have, I think this is sort of the most interesting finding here, that the fact that the subtherapeutic group did have persistent bacteremia, and that probably needs to be looked into further. But they also did not have a bad clinical success. So they did have a comparable clinical success when you looked at the other groups. So it's not really the low index level that's the final word here. There are other therapeutic interventions that patients received. And of course, they had dose changes. They subsequently went on and had dose changes. They also had surgery. They had so much supportive care. So, so that's just to bear in mind. So that's really, I think, what I wanted to say. So finally, just saying that we know that standard dosing frequently fails to achieve therapeutic levels. We know that the renal function is the primary driver many a times. Persistent bacteremia was associated. I'm saying that with certainty, but it looks like it was associated with subtherapeutic levels. TDM results, they obviously led to dose adjustments, and they did lead to improvement in target concentrations that we were aiming for. And we saw that we were increasing the administration frequency, but we were also using prolonged and continuous infusions, which I think is a really good intervention if you want to optimize if you don't have TDM. And we know that cefazolin is effective and safe because we did have a good clinical success rate overall. We did have low toxicity, and only 2 cases of acute kidney injury in the small cohort. And one of them was, like a good going AIN, and the other one, we don't know if they recovered. So most patients do recover from their AKI with time after sepsis. And then, of course, the comparable success rates, we didn't follow the patients through, right? We adjusted the doses. We did a lot more things to them. So could they have been rescued just with TDM guided dose adjustments, or were there other things that were going on? So that's something to consider as well. And that brings me to the end of my talk.
Wonderful. Thank you so much, Rekha. Very interesting data. And I think you should be very proud about that data collection. And congratulations to Leon as well for his work in supporting that.